Imagine you were in an emergency room, right? And a trauma patient has just been rushed through the doors.
Oh, wow. Yeah.
Yeah, she is losing massive amounts of blood internally, but you wouldn't know it just by looking at the standard monitors.
Right, because her vitals look fine.
Exactly. Her heart rate is completely normal. Her blood pressure is stable. By all conventional metrics, she looks totally fine. And the only way the medical team knows she's actually actively bleeding to death
Hmm.
is by listening to a second, entirely different heartbeat inside her.
Yes. It is wild. The standard diagnostic tools we rely on every single day just, you know, they stop telling the truth.
Right, because the biological baseline has been completely rewritten.
I mean, it really has. So for today's deep dive, we are looking at a massive stack of excerpts from a comprehensive medical textbook chapter.
And this one is titled Medical Surgical Disorders and Trauma Management in Pregnancy.
Right. And our mission today is to uncover how the body's normal, radical adaptations to pregnancy don't just, affect a growing baby, but how they complicate pre-existing conditions. They force doctors to completely tear up the rulebook for medical emergencies and trauma.
Exactly. Because for you listening, it is so easy to think of pregnancy mostly in terms of like a baby bump and maybe some morning sickness.
Yeah, the visible stuff.
Right. But what these sources reveal is just a massive system-wide physiological reboot.
It's essentially an endurance test, one that touches every single organ system, fundamentally altering the physics and chemistry of the human body.
Okay, let's unpack this. Starting with the literal engine driving this entire physiological reboot, which is the heart and the cardiovascular system.
The perfect place to start.
Yeah. So according to the text, a normal pregnancy causes a massive 30% to 45% increase in cardiac output and blood volume.
Which is just a staggering amount of fluid when you think about it.
Right. To put that in perspective, if a typical person has about 5 liters of blood, a pregnant woman's body manufactures almost 2 to 2.5 additional liters.
Yeah, it's an enormous amount of extra fluid to pump around the body.
So when does all that extra fluid show up?
Well, the bulk of that increase actually happens in the first trimester, and then it peaks around 20 to 26 weeks.
Okay.
The body builds this massive fluid reserve to ensure the placenta is adequately perfused with oxygen and really to create a buffer for the inevitable blood loss during delivery.
Makes sense.
Right. So a healthy heart simply hypertrophies.
Yeah.
It gets a little thicker and pumps a little harder to compensate for the extra workload. But a diseased heart, however, cannot adapt.
Right. And the text details how pre-existing heart conditions are categorized using the New York Heart Association functional classes, right? Roman numerals I through 4.
Exactly.
And class I basically means a person is generally asymptomatic with no real limitations.
While class 4 means they can't carry on any physical activity without severe discomfort or shortness of breath.
So if the blood volume increases by almost half, does that mean women who were totally fine before pregnancy can suddenly go into heart failure?
That is exactly what it means, yeah.
That is terrifying. It makes me think of like a standard residential water pump.
Oh, that's a good analogy.
Right. If it's suddenly forced to supply both the main house and, a newly built guest house at maximum pressure,
Yeah.
a slightly worn motor is just going to burn out.
What's fascinating here is the precise physiological why behind that pump failure.
Tell me more.
Well, the functional classification of heart disease isn't static during gestation. Doctors have to evaluate the mother at 3 months and then again at 7 or 8 months.
Because the volume keeps changing.
Exactly. Because of that 45% increase in output, a pregnant woman might progress from a relatively safe class 1 to a highly dangerous class 3 or 4.
Wow.
Simply because the slightly diseased pump cannot handle the sheer volume of the new fluid dynamics. The pressure just overloads the chambers of the heart.
That is intense.
And the danger actually spikes dramatically during the immediate postpartum period.
Wait, really? Postpartum?
Yeah.
But you would think once the baby is delivered, the strain on the heart would immediately go down, like the guest house is gone. You would think that, right?
Yeah.
But you have to look at the fluid dynamics.
Okay.
Throughout pregnancy, a lot of fluid leaks out of the blood vessels and into the surrounding tissues.
Which is why pregnant women often experience severe swelling in their ankles and legs, I assume.
Exactly. But at the moment of birth, the heavy uterus empties and intra-abdominal pressure drops dramatically.
Oh, I see where this is going.
Yeah, all that extravascular fluid in the tissues suddenly rushes back into the bloodstream all at once.
So the heart is just instantly flooded with volume.
Completely flooded, and if the heart muscle is weak, it just can't pump that incoming flood fast enough, which leads to acute heart failure.
The sources highlight two major conditions where this volume overload is especially lethal. First is Marfan syndrome, right, which is a genetic disorder affecting connective tissue.
Right, highly dangerous in this scenario.
Yeah, the text says if a woman has Marfan syndrome and an enlarged aortic root, the extra blood volume and pressure bring a severe risk of aortic dissection,
Meaning the main vessel carrying blood from the heart literally tears open.
which is just horrific. The maternal mortality rate can be greater than 50% in severe cases.
It's incredibly high.
And then there's peripartum cardiomyopathy, which is congestive heart failure that develops out of nowhere in the last month of pregnancy or the first 5 months postpartum.
And this is in women who had absolutely no heart disease beforehand.
That is just terrifying. Do they recover?
Well, in about half of those cardiomyopathy cases, the heart's left ventricular function resolves within 6 months postpartum. The pump basically heals once the volume returns to normal.
Okay, well, that's good for that half.
Yes, but for the other half, the prognosis is incredibly poor without major intervention. Sometimes they even require a full heart transplant.
Wow. Okay, so the heart is pumping 45% more fluid, but volume means nothing if that fluid isn't oxygenated.
Right, it's just moving empty trucks around.
Exactly. That massive demand for oxygen pulls the lungs and the blood directly into the crossfire. We read a lot about anemia in these chapters.
We did, yeah.
And the text makes a really crucial distinction. There's normal physiologic anemia of pregnancy, and then there's actual iron deficiency anemia.
The distinction really comes down to ratios.
How so?
So the body increases blood plasma, which is the liquid part of the blood, much faster than it can manufacture the red blood cells that actually carry the oxygen.
Oh, so the blood essentially comes diluted.
Exactly. That is physiologic anemia. The total number of red cells goes up, that their concentration drops.
Okay, I get that. So what about the iron deficiency kind?
Actual iron deficiency anemia, which accounts for about 75% of cases, happens because the developing fetus aggressively pulls iron from the mother's stores to build its own blood supply.
Now, if you're listening to this and wondering why a doctor can't just hand every pregnant woman an iron pill and call it a day, the reality of sickle cell anemia completely flicks that logic on its head.
It really does.
For women with sickle cell, routine iron supplements must be strictly avoided. The biology behind this is wild.
Yeah, because women with sickle cell anemia are almost never iron deficient, even though their blood oxygen levels are low.
Wait, how does that work?
Well, a normal red blood cell lives for about 120 days. But a sickle red blood cell has a very short lifespan, often just 5 to 10 days.
Oh, wow.
And as those cells constantly break apart, which is a process called hemolysis, they release all their iron back into the mother's bloodstream.
So the iron is naturally recycled.
Exactly.
Huh.
So if a doctor blindly prescribes routine iron supplements, they aren't actually treating the anemia.
They are causing iron overload.
Yes. Heavy iron deposits build up in the liver and the heart, causing severe organ toxicity.
So moving from the oxygen carriers to the oxygen intake, let's look at asthma. The text describes asthma's reaction to pregnancy as a strict rule of thirds.
Right.
In massive clinical observations, about 23% of women saw their asthma improve, 30% worsened, and the rest stayed exactly the same.
A literal roll of the dice.
Yeah, exactly, like a roll of the dice. But I have to question the physical mechanics of this. Wait, if the growing uterus is literally pushing up against the diaphragm, physically crushing the space the lungs have to expand, shouldn't asthma always get substantially worse?
You'd think so based on pure mechanics. But if we connect this to the bigger picture, we see that asthma isn't purely a mechanical issue of lung capacity.
It's an inflammatory airway disease, right?
Exactly. And the unpredictability of that rule of thirds comes from the profound chemical shifts occurring in the mother's body.
Like hormones.
Yes. Pregnancy naturally spikes circulating cortisol levels, which is the body's built-in steroid, and that reduces inflammation.
Oh, that makes sense.
Simultaneously, the body produces massive amounts of progesterone, and progesterone acts as a smooth muscle relaxant, naturally designed to keep the uterus from contracting prematurely.
Right.
But it also relaxes the smooth muscles lining the airways, essentially acting as a natural bronchodilator.
So for some women, this chemical cocktail completely counteracts the mechanical loss of lung space and is actively soothing their hyperreactive airways.
Exactly. It's entirely chemical warfare overriding structural limitations.
That is fascinating. And speaking of severe respiratory conditions, the text outlines the immense hurdles for women with cystic fibrosis.
Oh, yeah. This is a tough one.
Thanks to major medical advances, more women with CF are living longer and, choosing to get pregnant, but they face a terrifying math problem regarding calories.
Right, because CF doesn't just damage the lungs.
Right, it causes pancreatic insufficiency. The pancreas basically fails to release the enzymes needed to digest and absorb nutrients.
And their baseline caloric requirement just to maintain their own body weight is already incredibly high.
Just from breathing.
Yes, due to the chronic energy expenditure of breathing with damaged lungs and constantly fighting infections.
Wow.
So when you add the immense metabolic demand of growing a fetus, the mass becomes almost impossible to balance through normal eating alone.
Yeah, the sources mention that to support fetal growth and prevent severe maternal malnutrition, some of these women require nighttime nasogastric tube feedings.
Right.
They literally have a tube run down their nose into their stomach, pumping in high-calorie nutrition while they sleep just to keep up with the demands of the pregnancy.
It really highlights the extreme systemic toll. I mean, they are attempting to fuel a massive biological construction project while their own digestive system is functionally compromised.
Exactly. And while the heart and lungs are working at maximum capacity to supply oxygen and fuel, there is a completely silent negotiation happening on a microscopic level.
The immune system.
Yes, the mother's immune and nervous systems have to establish a really delicate truce. I mean, the immune system is designed to destroy anything containing foreign DNA, right?
That is its sole purpose.
And the fetus shares half its genetics with the father. So by all biological rules, the mother's body should attack and reject it.
But it doesn't. The maternal immune system has to selectively stand down. It alters its defensive posture just enough to tolerate the fetus without leaving the mother completely vulnerable to outside infections.
The complexity of managing this while dealing with pre-existing neurological issues is just staggering. Let's look at epilepsy.
Yep.
Doctors face an incredibly dangerous tightrope walk here. You have to control the mother's seizures because a grand mal seizure deprives the fetus of oxygen, which can be fatal.
Right.
But the medications used to stop seizures are frequently teratogenic, meaning they cross the placenta and cause severe birth defects.
Yeah, valproic acid is specifically called out in the textbook as highly dangerous.
Because it's associated with major physical malformations.
Yes, and severe cognitive issues, including a high risk for autism spectrum disorders.
So what do doctors even do?
The clinical strategy requires finding a safer anticonvulsant and using the absolute lowest effective dose.
Okay.
But remember that 45% increase in blood volume we discussed earlier.
Oh, right. Does that wash out the meds?
Exactly. That extra fluid dilutes the seizure medication. Plus, the mother's liver and kidneys are working overtime, clearing drugs from her system much faster.
So they have to constantly monitor her blood levels.
Yes, and often increase the medication dosage throughout the pregnancy just to maintain the baseline protection. It is a constant, careful balance between the threat of a seizure against the toxicity of the drug.
And to help counteract some of the risks from those medications, these women are prescribed massive doses of folic acid.
Like up to 4 to 5 milligrams a day.
Which is roughly 10 times the normal prenatal dose, because folic acid is critical for closing the neural tube early in fetal development.
Absolutely.
But the precautions extend well past the delivery room. The text highlights incredibly specific postpartum safety rules, because severe sleep deprivation is a massive trigger for epileptic seizures.
And a newborn virtually guarantees severe sleep deprivation.
Right, so the medical protocol actively advises mothers with epilepsy to have someone else handle all nighttime feedings.
They are even instructed to never bathe the baby alone.
Yes, and to change diapers on a pad directly on the floor instead of up on a changing table. Because if the exhaustion triggers a seizure, the mother falling from a standing position while holding the infant could be catastrophic.
It is a profound example of adapting lifestyle to mitigate risk during a period of extreme neurological vulnerability.
It really is. Now, let's look closer at that immune system truce. Here's where it gets really interesting.
Or the autoimmune phenomena.
Yes. The sources detail how different autoimmune disorders react completely differently to the pregnant state, with conditions like myasthenia gravis or systemic lupus erythematosus. Pregnancy can trigger brutal, dangerous flares.
Right.
But multiple sclerosis, MS, acts differently. MS often goes into complete remission during pregnancy. Is the mother's body suppressing its own immune system so it doesn't reject the baby, and accidentally fixing the MS in the process?
You're touching on one of the most remarkable phenomena in human biology, honestly.
You're right.
Yes. MS is characterized by the immune system mistakenly attacking the myelin sheath, which is the protective covering of nerves in the central nervous system.
Right.
To prevent the rejection of the fetus, the pregnant body fundamentally shifts its immune profile. It promotes a state of immune tolerance, specifically suppressing certain inflammatory T cells.
Okay, I'm with you.
For a woman with MS, this chemically mandated truce forcefully stops the immune cells from attacking her own nervous system.
So the attacks just cease.
Exactly, the attacks cease, and she experiences complete remission.
But it doesn't last, does it? The textbook notes that the highest risk for an MS relapse is actually in the first few months postpartum.
Sadly, yes. The moment the placenta is delivered, that powerful immunosuppressive shield vanishes.
The biological truce is over.
Exactly. The immune system rebounds, often aggressively, which is why those postpartum flares are so common and require intense monitoring.
The body's ability to orchestrate that temporary ceasefire is amazing. But that same resourcefulness creates a complete nightmare for doctors trying to figure out if something goes wrong.
Oh, the diagnostic disguise.
Yes, because we aren't just dealing with microscopic immune cells acting strangely. The major organs inside the abdomen are literally being evicted from their normal locations.
Yeah, diagnosing a pregnant patient requires a complete spatial recalibration. You simply cannot trust standard anatomical landmarks.
I kept reading about appendicitis. It is the most common non-obstetric surgical emergency in pregnancy. But the text notes a staggering 40% rupture rate in pregnant women.
Which sounds crazy, right?
Right, how do you miss an exploding appendix? The pain is usually unmistakable.
Usually, yes.
But it turns out as the uterus grows, the appendix is pushed physically upward and shifted to the right, far away from its normal spot in the lower right quadrant of the abdomen.
It migrates.
It's like trying to find a specific book in a library right after an earthquake has rearranged all the shelves. The parts are migrating while you're looking for them.
That's a great way to put it. Furthermore, the clinical signs of an inflamed appendix are completely masked by the normal symptoms of pregnancy.
Right, because a standard patient with appendicitis presents with nausea, vomiting, and an elevated white blood cell count.
But a healthy pregnant woman already has nausea, vomiting, and a naturally elevated white blood cell count simply from being pregnant.
The signal is entirely lost in the noise.
Entirely. And a ruptured appendix puts the pregnancy at extreme risk for widespread infection and preterm labor.
But confirming the diagnosis is another huge hurdle. I mean, in a non-pregnant patient, you just order a CT scan. But the radiation from a CT scan poses severe risks to fetal development.
Which forces the medical team to rely heavily on ultrasound and MRI.
Right.
Tools that are safer, sure, but sometimes much harder to interpret quickly in a crowded, fluid-filled abdomen.
And the shifting anatomy isn't the only culprit. Hormones play a massive role in this diagnostic disguise. Take the gallbladder.
Oh, the gallstones.
Yeah, the incidence of gallstones skyrockets during pregnancy. Why? Because the exact same hormones keeping the uterus relaxed, estrogen and massive amounts of progesterone, also relax the smooth muscle of the gallbladder.
So the gallbladder just stops squeezing efficiently.
Exactly. The bile becomes sluggish, it just sits there and it forms stones.
It's the physiological cost of maintaining the pregnancy. The hormones don't selectively target just the uterus.
Right.
They bathe all the smooth muscle tissue in the entire body.
And that identical mechanism explains the extreme danger of urinary tract infections. The progesterone dilates and relaxes the ureters, the tubes carrying urine from the kidneys to the bladder.
Right.
The text stresses that asymptomatic bacteria, which is finding bacteria in the urine even if the mother feels perfectly fine, must be aggressively treated with antibiotics.
Because those ureters are relaxed and widened. Right?
Yeah. The bacteria face zero resistance. They climb straight up into the kidneys, causing a severe infection called pyelonephritis, which can rapidly spiral into maternal septic shock.
So a minor silent infection that a non-pregnant body would easily flesh out suddenly has a paved highway directly to a major organ.
Exactly. Even the skin gets pulled into the diagnostic confusion. Doctors have to distinguish between polymorphic eruption of pregnancy, or PUPPP, which is a maddeningly itchy rash that usually starts in abdominal stretch marks.
And intrahepatic cholestasis of pregnancy, or ICP.
Right. An ICP often presents with intense itching, especially on the palms and soles of the feet, but completely lacks a rash. PUPPP is miserable but entirely harmless. ICP is caused by elevated liver bile acids spilling into the bloodstream.
And those bile acids are highly toxic to the fetus.
Really toxic.
ICP poses a severe, unpredictable risk of sudden stillbirth. The only way a physician can tell the difference between a harmless skin irritation and a lethal liver complication is by immediately running blood panels to look at those bile acid levels beneath the surface.
Okay, so if finding a migrating appendix or diagnosing an invisible liver condition is hard, dealing with multi-system trauma requires a complete teardown of the emergency rulebook.
It really does.
If a pregnant woman is in a major accident, the standard protocols have to shift entirely. The text notes that motor vehicle accidents are a leading cause of non-obstetric maternal trauma.
Yeah, it's a huge issue.
And there's a tragic psychological element here, too. Many pregnant women avoid wearing seatbelts out of fear that the belt itself will crush the baby in a crash.
But the physical physics of a collision dictate otherwise.
Right.
The force of being ejected from the vehicle or suffering blunt force trauma to the abdomen by striking the steering wheel is exponentially more lethal for both the mother and the fetus and the localized pressure of a properly positioned restraint.
And when trauma does occur, the medical team is bound by what the text calls the golden rule of pregnancy trauma. Resuscitate the mother to save the fetus. Prioritizing the fetus first actually endangers both.
Exactly.
So what does this all mean for the EMT on the scene? Think about how psychologically agonizing that must feel for a first responder. Every human instinct screams at them to worry about the baby, right? To check the infant's vitals. But they have to force themselves to ignore the pregnancy and focus entirely on the mother's airway, breathing, and circulation.
This raises an important question about how our emergency personnel are trained to handle extreme psychological stress.
Yeah.
They must suppress their deepest protective instincts, relying entirely on the protocol that fetal survival is 100% dependent on stabilizing the maternal engine.
And the modifications to cardiopulmonary resuscitation, or CPR, vividly illustrate this. If a woman in the later stages of pregnancy goes into cardiac arrest, you cannot perform standard CPR with her lying flat on her back.
No, absolutely not.
Because the heavy, fluid-filled uterus will physically crush the inferior vena cava against her spine. That is the massive vein returning all the blood from the lower body back to the heart.
Right, and if that vein is compressed, blood return stops entirely. You can perform chest compressions perfectly, but you are squeezing an empty heart.
Which means there is no blood to circulate to the brain. So the emergency team literally has to manually push the uterus to the left side or wedge a rolled towel under the mother's right hip to tilt her entire body, freeing that vein so blood can flow again.
It's such a critical adjustment.
And even the placement of the automated external defibrillator, the AED paddles, has to change. The pads must be placed one rib space higher than normal because the growing uterus pushes the diaphragm up, displacing the heart higher into the chest cavity.
It requires extreme situational awareness from the responders.
It really does. And then there is the terrifying reality of massive blood loss, which brings us back to that 45% increase in blood volume we started with.
The hook from the beginning.
Exactly. The woman bleeding to death with perfect vital signs. Because a pregnant woman has liters of extra blood, she can hemorrhage massively internally before she ever shows the standard signs of shock, like a racing heart or plummeting blood pressure.
Her extra volume completely masks the emergency.
So what's the safety net then?
The clinical safety net in a trauma setting becomes the fetal monitor. The monitor isn't just checking on the baby. It acts as an internal maternal oximeter.
Wait, how?
When the mother begins losing blood, her body initiates a ruthless triage. To protect her own brain and heart, her circulatory system forcefully clamps down on the blood vessels leading to the uterus.
Oh, shunting the remaining blood away from the fetus.
Exactly.
So the baby becomes the canary in the coal mine. The very first sign that the mother is hemorrhaging internally is a change in her own pulse or blood pressure. The first sign is a sudden, drastic drop in the fetal heart rate, signaling to the doctors that the mother's body is silently going into shock.
It perfectly illustrates the total physiological interconnectedness. The maternal system sacrifices the peripheral organs, including the uterus, to save the central nervous system.
It is chilling, but also an awe-inspiring piece of diagnostic biology.
Absolutely.
So, to you listening, after tracing the path of this blood flow, after exploring the chemical warfare in the lungs and the invisible truces happening in the immune system, it is impossible to look at a pregnant woman and just see a baby bump.
You are looking at a profound systemic endurance test.
You're seeing a heart pumping for a new biological house, organs physically pushed into the margins, and a blood volume that actively defies normal emergency logic. It is an incredibly resilient, adaptive human body.
The resilience is unmatched. And I'll leave you with a final thought to ponder.
Okay, let's hear it.
We discussed how pregnancy naturally pushes the human cardiovascular and immune systems to their absolute maximum limits, to the point where the chemical signals of pregnancy can cause a severe autoimmune disease like multiple sclerosis to temporarily vanish.
Right, the remission.
Exactly.
Yeah.
So if scientists can fully map the specific chemical and hormonal signals that command the maternal immune system to stand down, could those discoveries eventually unlock entirely new therapies?
Oh, wow.
Could the secrets of maternal immune tolerance one day be artificially replicated to cure severe autoimmune diseases or prevent organ transplant rejection in non-pregnant people?
That is a staggering possibility. Because when we study this, we aren't just looking at how to fix a broken diagnostic machine. We are realizing the machine has the blueprint to rebuild itself from the inside out.